Good morning, everybody. Wow, what a pleasure this morning to have the honor of introducing a longstanding colleague, Dr. Linda Prine, who's been Director of Women's Health at the Institute for Family Health for as long as I can remember. She's also a co-founder of the Reproductive Health Access Project, a professor of family medicine at the Icahn School of Medicine. Linda graduated from Cornell Medical School and completed her residency training at Montefiore's Family Practice Residency in Social Medicine. She's active in New York State Academy of Family Physicians and has been a progressive voice for women's health in many other organizations as well. To say that Dr. Prine is a national leader in reproductive healthcare advocacy is an understatement. She's been the invited guest lecturer at grand rounds in programs across the country, has presented on women's reproductive health at the Society of Teachers of Family Medicine, the American Public Health Association, the Association of Reproductive Healthcare Professionals, and the American Academy of Family Physicians. And if I'm not mistaken, she's also received national awards for almost all of them, among others. Dr. Prine has authored many articles and research papers, but most importantly, has been a teacher, a mentor, a colleague, and an inspiration to so many others in the field. Dare I say that her followers can be found widely across the country, and she continues to inspire us with her work. Dr. Prine has been working at the Institute since 1994. During that time, countless residents and faculty have come to work with us because Linda is here. I thank her today for all that work and for putting together such an esteemed panel to discuss women's health advocacy this morning. Linda, it's all yours.
Thanks, Neil. I just want to say for my co-panelists, that is not the bio that I wrote.
Well, you're not supposed to write your own bio. I do have some privileges left.
Okay. So let me tell you who's going to be doing this panel with me. First, Ruth Lesniewski, who's worked at the Institute, we just figured out, for 32 years as an attending and faculty. Lisa Maldonado, who is one of the founders and the current executive director of the Reproductive Health Access Project. Lucia McClendon, who came through our residency and our fellowship and is the assistant residency director at the Harlem Family Medicine Residency Program. Ginger Gillespie, who was one of our early residents at the downtown, then the Beth Israel Residency Program, who's currently the medical director at the 17th Street practice. Razel Raymond, who was a fellow at the Institute after training in family medicine in Alabama, and is now working in Detroit, Michigan, where she trains a fellow there and provides abortion care, both at some local clinics, as well as having her own Pills by Post practice, where she mails pills and works for Aid Access. Maggie Carpenter, who also works for Aid Access, who was one of our faculty people at our upstate site and has her own little private practice called Nightingale Medical, who also works for Hey Jane mailing pills. And I think there might be one more I'm forgetting. So that's our group, and we're going to go ahead and get started with Ruth for our first slide.
Hi, everybody. Do people see the first slide?
Yeah, sorry, I just have to cancel the spotlight that I have on. I'm so sorry about this.
Okay. So I'm going to talk a little bit about history of abortion at the Institute for Family Health. In 1999, knowing that mifepristone was likely to get FDA approval soon, we started working on adding abortion services at IFH. A small group of clinicians and activists began meeting monthly on the 6th floor of Sydney Hillman Family Practice. We expected the logistical barriers to be ironed out in a few months. Little did we know how complex this would be. We focused on getting buy-in from IFH leadership, addressing legal and reimbursement issues, and educating coworkers. To prepare for adding abortion services, we beefed up contraception and did values clarification workshops with all types of staff members. These early efforts were exhilarating. Patients really appreciated being able to get abortion care from their trusted PCPs. With tremendous help from Lisa Maldonado, our group turned into a nonprofit organization and began to apply the lessons we learned to help others accomplish the same things. Next slide for Lisa.
So the Reproductive Health Access Project was founded in 2005. And just as Ruth said, we literally grew out of all these efforts that started at the Institute for Family Health. RAP, as we call it for short, mobilizes, trains, and supports clinicians, primary care clinicians, to provide reproductive health care. We fill critical gaps in education and service delivery. And by centering communities with the least access, we strive to make access to reproductive health care more equitable. The Institute has been a tremendous partner from the get-go. We've piloted many of our projects with them, like the fellowship, the LARC Training Center, and next slide. Many of the clinical tools and resources that we share on our website, and we have 199 of them, and these are used all around the world, really came out of the direct needs of the patients and the clinicians that provide care at the Institute for Family Health. So RAP has grown a lot since 2005. We are now a national remote organization. We have staff around the country. We have fellowship sites in 5 states, and we have a strong national network of primary care clinician activists with chapters in 25 states. Next slide. So over the years, and it's been quite a few years, we built our base by really going and presenting and connecting at conferences. We would go to primary care conferences locally, regionally, nationally. We would present talks, do CME, host happy hours, and just try our best to connect with like-minded folks, and then keep those connections going, honestly, via a listserv. And then through that listserv, we really were able to engage people, connect with people, and grow our organization, and support folks to become activists in policy, both state policy, but also to become activists within their professional organization, trying to change the way that, for example, the American Academy of Family Physicians speaks out on issues like this. And I don't know if you all follow the AAFP, but just the other day, they issued a statement denouncing the horrible law that was passed in Oklahoma. And it really was the efforts of the folks in our organization who are engaged in the AAFP to get the organization to speak out so promptly and so strongly against that anti-abortion legislation. Next slide, and I'm gonna pass it over to Ginger.
Hey. So I'm going to take us back to some of the earliest days of the residency and how we got started. This is a poster that highlights our procedural training and how we grew the procedure clinics. So in 2000, we received 3 years of grant funding to integrate abortion into primary care. We initially dedicated these sessions focusing solely on abortion care. We started those services for abortion in 2001 with medication, and in 2003, we added procedural abortions, manual vacuum aspiration, or MVA. So then working towards that main goal of mainstreaming abortion into the provision in primary care, we combined those abortion procedures with our IUDs, pregnancy ultrasounds, and all the non-reproductive healthcare procedures we do now, such as toenail removals, biopsies, cryo treatments, and really integrated all these procedures together. So these sessions became very, very popular with the medical students and the residents, and they also became a very important recruiting tool for prospective residents, who eventually many came to join us, train, and go on to do their own work in abortion care. We also now see all these clinics spread out over all our IFH sites at Cadman, Walton, Harlem, and it's many of our graduates who started and staff these clinics. So next slide. So how do we begin to fit research in? So within the procedure clinics, we were able to start doing a number of important studies, but mainly a lot of the studies were to try to challenge the REMS from the FDA. So The REMS is a risk evaluation and mitigation strategy. It's basically a safety program that the FDA can require for certain medications with serious safety concerns to help ensure the benefits of medication outweighs its risks. So, you know, when we look at mifepristone, we always ask, like, why did we really need this? When you look at the serious reactions you can see from mifepristone and compare them to an over-the-counter drug such as ibuprofen, right? There's really no comparison. So obviously, clearly there were barriers that needed to be challenged, largely political, and many, you know, that we started to work on. So next slide, I'm going to show a couple of the studies that we worked on. We partnered a lot with an organization called Genuity and did multiple studies, both on safety and tolerability of different protocols for medication abortion. This particular study was an interesting one that really needed to be done to show that women could take a pill home and swallow it. So 301 women were randomized to either swallow mifepristone in the office or at home. And lo and behold, the outcome was that women could very successfully take mifepristone at home. And this was highly tolerable and desired and allowed a lot of flexibility and comfort for women to have abortions in the privacy of their own home. So this begins to change the REMS, right? So now we don't have to directly hand women pills and watch over them. They can have some flexibility. Good. So eventually this leads to a change in the REMS where during the pandemic, that whole restriction is lifted and we do not have to be dispensing pills directly from the clinic, and there becomes flexibility in being able to mail pills out to women. Next slide. So this is also an interesting study that we did that really leads to a more hands-off approach to medication abortion. This is, we often refer to the study as a no-touch abortion. So it's a simplified medication abortion screening. This was a demonstration project, again, with Genuity. So in this study, 365 women were enrolled across multiple sites, and they agreed to have their medication abortion without some of the usual pre-screening ultrasound or pelvic exams. So in the outcome of this, we saw that there were no more serious adverse events that would have been prevented had we done those more invasive procedures prior to medication abortion. So obviously this leads to a lot of help in developing telemedicine and being able to do more remote work for medication abortion. So these were both pretty key studies that we did. And none of this work could have been done without our amazing fellows who helped all the way along with all of this work. So I'm going to turn it over to Dr. McClendon now to discuss the fellowship.
In 2007, the Institute, along with RAP, founded the Reproductive Health Fellowship. This would not have been possible without a large donation from Maureen Falenke, wife of the late Dr. John Falenke, a staunch repro health advocate and early family physician in New York City. This donation funded our first six fellows. To date, we have trained 30 reproductive health fellows at the Institute in just 15 years. As fellows have graduated and moved to other states, so did the fellowship. Today, the Institute, as Lisa said, is just one arm of the RAP Fellowship and now has sites in Boston, Seattle, Detroit, and New Jersey. As the flagship program, our New York City site trains 2 fellows per year and is the only RAP Fellowship providing abortion care and training within the FQH model. Next slide. During the fellowship year, fellows not only master abortion care, family planning services, and outpatient procedures, but they also learn about reproductive justice, patient-centered GYN care, and how to advocate for policy change. In order to foster leadership and advocacy skills within our fellows, they participate in a variety of different activities, including presenting at state and national conferences, leading papaya workshops for students and community members, working on research projects, precepting residents and students, and last but certainly not least, they are primary care physicians at the Institute. Next slide. An important arm of the fellowship is the Leadership Training Academy, which is run by Physicians for Reproductive Health. LTA is a series of seminars which teach public speaking and advocacy through the lens of storytelling, specifically telling the stories of our patients, and especially those patients who have suffered when policymakers and stakeholders didn't take them into consideration. After all that training and exposure, Our 30 fellows have gone on to be leaders and advocates within residency programs and medical schools. They're medical directors at multiple Planned Parenthood sites and FQHCs around the country. They're running telemedicine abortion startups, and they are leading us at the state and national level within the AAFP. Next up, Razel, one of our former fellows, who will talk to you about telehealth abortion care, Plan C, and her trailblazing work in Michigan.
Hi. So basically, telemedicine abortion was the brainchild of the Netherlands-based physician and activist Dr. Rebecca Gompertz, who in 2005 founded an organization called Women on Web, which mailed abortion pills from a pharmacy in India to women in countries throughout the world where access to abortion was restricted. Originally, the United States was not part of the one of the countries which Women on Web serviced. However, by 2018, the access to abortion in the United States had become so dire that Dr. Gompertz founded another organization called Aid Access, whose mission was to help people who, due to cost, distance, or other factors, might not be able to obtain an abortion in the United States. Aid Access currently serves all 50 states. 20 of those states are covered by 9 US-based clinicians who are able to mail medications from US-based pharmacies to patients in the United States. Telemedicine abortion usually follows either a synchronous model or an asynchronous model. In the asynchronous model, the patient fills out an online health history form and the provider reviews it at a later date. Next slide. Over the past 2 years, we've seen quite a few different telemedicine abortion services emerge. The vast majority of them are run and owned by family medicine physicians, nurse practitioners, and PAs. With the onset of COVID, telemedicine abortion proved to be especially critical in ensuring continued access to care. Telemedicine abortion has been extremely important in allowing women in red states to obtain abortion irrespective of local mandates or law. Several critical support organizations have emerged around the telemedicine abortion movement. These organizations provide informational resources, emotional support resources, legal support resources, and financial support resources, to name a few. I'm just going to briefly highlight one of them. Plan C is an organization comprised of public health advocates, researchers, and social justice advocates who provide information resources for self-managed abortion with pills. All listings on the Plan C site have been independently vetted. The listings are organized by state, type of service, i.e. telemedicine versus online pharmacy, and price. Next slide. Okay. These are just a few of the organizations, as you can see, and where we serve. And then I'm going to let Dr. Prine discuss the M&A Hotline, which is another organization which supports all of these services.
Thanks, Razel. So the next slide. So I'm going to take you back to 2018 when a group of us on the access list were getting really frustrated under the Trump administration, which at that time we felt was thoroughly attacking reproductive rights. Little would we know that 4 years later it would be even worse. But anyway, we were talking about how we could mobilize some resistance and wanted to do something more radical. So a rump group of us formed a separate listserv for a few weeks and started discussing what we could do, and didn't really come up with anything. But the most kind of radical out there thing we knew of that was going on was Rebecca Gompertz Aid Access. So I got in touch with her. I knew her from back when her film, the film Vessel, which if you haven't seen this documentary is really amazing, about her Women on Waves work, was screening in New York City. And I had invited her over afterwards to talk to a group of residents and local family doctors. So I got back in touch with her and asked her if she had any needs that we could get involved in. And she was like, yeah, we're really overwhelmed. We need someone who can answer medical questions for our patients as they're going through their self-managed abortions. She had a helpline, but it was of lay people, and she had 2 doctors who were doing support, but it wasn't enough for all the questions they were getting. And the Aid Access website just takes emails from people. So when anyone felt like they had an urgent need, they didn't really have a way to get an immediate answer. So One of the other people from this rump group and I decided we would work on forming a hotline that people who were doing their self-managed abortions could call. We met with people who knew about digital security, and we met with lawyers about the legality of giving medical advice to people who weren't our patients, and asked questions about liability and so on and so on. We researched end-to-end encrypted apps, and I learned more about non-medical things than I had for a long time in my life. And we formed this hotline. There, out of the original 80, there were 12 of us who decided we wanted to volunteer and make this happen. And we got some small grants. We commissioned a web designer. We hired a scheduler, and we launched our hotline. It originally was for about 10 hours a day. And over the years since it started in November of 2019, it's increased to 16 hours a day. We currently have 2 9-hour shifts that people take, and we have 40 volunteers. Actually, last night we just increased by 10 more. And we're getting ready to change our shifts to 6 hours because it's gotten so busy that it's just not possible to be on for 9 hours at a time. So the next slide, I'm going to switch gears a little bit and talk about what other things are happening kind of in preparation for what will be a huge change to Roe v. Wade when the Supreme Court makes their decision in June or July. What we're also working on is trying to expand abortion care in primary care, and activists in many of our big city blue states are trying to get primary care clinics to step up and offer abortion, because if Roe falls and, for example, Pennsylvania people are coming to New York City to get abortions, there's not going to be room for there's not going to be room for New York City patients to go to Planned Parenthood to get their abortion pills. We really need to be able to take care of our own patients. And that's the message, as the Institute has done for all of these years. Other primary care organizations need to step up. So next slide. The Primary Care Development Corporation is working with us on this strategy and plans to host a webinar with our 2 fellows in May about how to do medication abortion at your primary care site. And the advocacy will continue through the Reproductive Health Access Project. It's also happening in Chicago with the Midwest Access Project, where they're trying very hard to get their primary care people to step up and offer abortion services. This is a lesson that we've learned from Texas, because what has happened in Texas as abortion became inaccessible there is that people flooded Louisiana, Oklahoma, and New Mexico, and local people can't get into the abortion clinics. So we need to have a backup plan. We need to have primary care available as a place where people can get abortion pills up to 11 weeks from their last menstrual period. So next slide. And this is Maggie.
Hi. So I think everybody is kind of wondering what to expect if Roe falls in June or July, and actually starting to prepare for what that is. Basically it comes down to what is your zip code. Access is going to be related to your location. And as we've already made reference, that has already happened over the past 4 or 5 years with, abortion deserts across the country. So about half of the states in the United States will probably outlaw abortion. There are a lot of trigger laws, as well as previous laws that banned abortion that were never removed from the books. But when Roe passed in '72, it stayed, they just kept them on there. And so as soon as this happens, if it happens, probably happens, then these laws will go back into effect. And that's why there'll only be about half of our states that will allow abortion. Many of the services will not be affected. And I think that's important. I think, aid access, as mentioned, started because there was already so many restrictions. The Plan C website is excellent for people trying in these states that are going to ban it to find access to pills. And there are multiple companies besides the ones that offer There are a lot of medication, just prescription. They just send pills through the mail. I haven't figured out exactly how they do it, but they do. And the M&A hotline has really become critical to people who cannot find access. Approximately, I'd say half of our phone calls on the M&A hotline are people looking to find pills from states that have already passed lots of restrictions. And states now, as people have probably read in the news, like Missouri, are trying to restrict not only the ability to get an abortion within a state, but try and restrict their residents from even traveling outside of their state to find, to get access to abortion. As well, things have kind of changed that the prosecution, which used to go after mainly providers, is now going after anyone who aids them, as well as the people who are trying to access an abortion themselves. And these penalties are not only civil, but also criminal. So there's a lot of stuff going on. Next slide, please. So this map really wonderfully demonstrates what this post-Roe world could look like. It's from the Center for Reproductive Rights. The states that are, dark red here are hostile. These are the states that are going to be going after people trying to prescribe pills within those, to send pills to these states, as well as their residents, leaving. The states that are red are not going to be protected from having abortion access. The states that are yellow, it's protected. And then the blue are the states that are trying to expand access. Next slide, please. And there are things that these blue states can do and are doing already to try and ensure more equal access. This is an excellent editorial that sort of outlines some of the things that are being discussed. Next slide. So as this article sort of talked about, we are about to begin the abortion wars. And the laws regarding the issues are extremely murky. There's issues mainly comes down to state versus federal laws. There's state versus the FDA. There's already been legislation proposed in Connecticut, California, New York, Vermont, and Washington. Has not been passed, but there are proposed laws that would allow prescribers within these blue states to prescribe to people across state lines. Of course, that's going to require protection. Some of the issues that these laws address are protecting the provider's privacy and safety, ensuring that their medical licenses are not going to be revoked, ensuring that they have malpractice, as well as preventing them from requiring them to go to court to do depositions and to be extradited. So there have already been some legal cases that have some precedent in these issues. Many people may have seen that in Massachusetts, they tried to restrict use of certain opiates, and that was found in favor of, they can't restrict an FDA-approved drug. There's also a current case down in Mississippi where they have restricted use of mifepristone to less than 8 weeks. And Gen Biopro, one of the two makers, the two distributors of mifepristone in the United States, has a lawsuit pending on that. So there are a lot of great legal minds sort of working on this. The legal battles are going to need to be fought on many different channels. So we need our legislators, we need our attorney general's offices, we need our providers, we need our malpractice insurers, and we need law enforcement to sort of help and come to the plate on this issue. So this could really be a whole 1 hour talk. So I'm just trying to condense it into our 3 to 5 minutes, but those cover some of the major issues that we're talking about. Thank you.
So we wanted to take it back to questions from people. And we're hoping that all of you can take turns, put something in the chat, raise your hand. Autumn's going to moderate.
Thank you so much, everybody, for this wonderful, wonderful presentation this morning. There were some components of it that were a little scary to me personally. In particular, people like you are saying that Roe v. Wade is going to fall, but some say for many parts of the country, Roe doesn't even exist anymore. I wonder if anybody can speak to that.
Hi, I can talk a little bit about that. I mean, I think Maggie just did like a really good job of talking about some of the issues that we're facing right now. But yeah, for many parts of the country, Roe is irrelevant. For many people all over the country, Roe is irrelevant. Medicaid doesn't cover abortion unless the state decides to kick in, and about only 17 states in the country do that. People have to jump through so many hoops, cross picket lines, travel far just to get abortion care. Clinicians to learn about abortion care, it's also the same. They have to really make an effort to get the training. Only 5% of family medicine residencies provide abortion training. So it's a really stigmatized, marginalized part of healthcare. And so I think that, you know, Roe is already irrelevant. And I think it's probably just going to get worse. I'm sorry to be so negative, but that's I don't know if anybody wants to add on to that.
I could take Andrea Maritato's question in the chat about can states extradite doctors for providing abortion. Well, this is our fear that if, for example, I were to mail pills to people in Texas where I was giving them to women who are beyond their heartbeat bills outlying gestational age, which is about 6 weeks, that I could be charged with breaking the law in Texas and then extradited to Texas to go to trial. So that's why we need to, I mean, I'm not doing that. I'm not mailing pills to people in Texas from New York State. But if we could get these laws passed that Maggie was citing, then we would be able to. And that's really going to be the difference for so many people of access versus none. I mean, most states are preparing, most blue states are preparing for people to come to their state. They're, Planned Parenthoods are trying to figure out how to ramp up their services, and laws are being passed to pay for abortions from out-of-state people. And all sorts of preparations are being made, but what about all the people who won't be able to travel? And that's basically the poorest of the poor. And so it's an equity issue. It's not enough to just make your state abortion friendly. You have to be able to reach outside of your state and provide care for people who are in other states, or else there's going to be a huge number of people left out of access altogether. And those are like the single mom with 4 kids who cannot travel. And those are people that we really need to be there for. And that's why we need to be able to mail pills.
I'd also add that in addition to the, with the extradition, it'll probably mean that anybody who does decide to prescribe across state lines really can't go to any of the states because of being at risk of being, if we can't be protected by New York State if we're in Texas.
We have a question here in the Q&A. How do these new regulations affect those who prescribe MABs over state lines? Any insight into how physicians, any insight on how physicians in soon-to-be hostile states are navigating the hostility? Excuse
me. So I'm in a purple state. I'm in Michigan, and Michigan has a pre-Roe ban. A 1931 law that makes abortion illegal. If Roe falls, then the ban goes back into effect. So we have been discussing various different ways in which we can challenge the ban. We're looking at a constitutional amendment, which would guarantee the right to abortion within the state. Just yesterday, as a matter of fact, the ACLU and Planned Parenthood filed a lawsuit against the pre-Roe ban to get it eliminated before Roe falls. And our Governor Whitmer filed another lawsuit against the state prosecutors that would prohibit them from going after any abortion provider should Roe fall. So there are different ways that I think states can navigate this. And I think that someone asked in the Q&A, how can we get rid of the Hyde Amendment? Yes, we would love to get rid of the Hyde Amendment. That's just one aspect of it. However, I think we really need to start looking locally and really boost up our local advocacy to ensure access throughout the country.
Thank you. Another question, we're having them coming fast, so I'm going to read them off and prioritize the best I can. Several of our graduates from our residency programs would like to provide MABs, but are working at an FQHC. Are there any resources to assist them in setting up access through their sites?
Yes, just have them email me, Lisa Maldonado at reproductiveaccess.org. You can also go to the Reproductive Health Access Project website, reproductiveaccess.org, and we have an FQHC medication abortion toolkit, and it kind of walks you through different things you can do, things that have been successful for other FQHCs to integrate. And we're happy to coach you and support you in that process. I think it's great. I think it can happen, but it will take some doing, and you definitely need supportive administration backing you up and willing to work with you on this. And I think that is probably the most important thing that is needed.
Yeah, I want to just speak to that for a minute, because I think it's so important that people understand that the Hyde Amendment doesn't restrict people from doing abortions in federally qualified health centers. That is a big misconception. What it restricts people from doing is using federal funds. And interestingly, in the community health center world, every dollar that comes in the door for things that are supposedly in your federal scope is considered part of the federal funding. But we actually, I believe, were the first people in the entire country to be audited for this. We were audited at Wetland. It took, I think, over a year and a half for us to finally clear the audit at the federal level. But literally, just by keeping all of your financial records and all of the costs and segregating everything that gets done into a separate cost center and having sources of revenue that basically are outside of the scope of practice, federally qualified health centers can do abortions. But it's really, in this environment, especially, I think it's critical that the finance people and the administrative people are all on board. And that's what, we've worked so closely together, all of us, to sort of make sure that this happens. We're surprised that we got audited, but, managed to get through a really, probably the most intensive audit we'd ever had of any of the financial issues. And it took a long time and a lot of work at the federal level from people who were our friends in HRSA to really to make that happen. So yeah, it can be done, and we should be encouraging it, because there's thousands and thousands of health centers in communities across the country, and that what an incredible opportunity for access. And I think we should think about how that can be. How we can promote that more openly in relationship to really articulating the procedures. So I'm excited to know. I didn't know that RAP had tools for this. So how do we get the other health centers to know that RAP has tools for this?
Yeah, we're working on it. I mean, I think the collaboration with Primary Care Development Corp could be a really great thing. They have connections with primary care providers all across the country, and partnering with them to support people. We are thinking of launching like a Project Echo type thing on integrating a medication abortion into your health center. So that's something that we're working on. But talk about it with your providers, with your colleagues. I think that's a start.
I'd also add that, sort of as you're mentioning, there is this misunderstanding that the Hyde Amendment prohibits FQHCs from providing abortion care. Be careful with the laws that are going to be coming up, sort of post Roe. Everyone assumes, oh, well, you can't do telehealth across state lines, or you can't do this. There's a lot of lore. And I think unless you really look at the laws, be careful not to perpetuate that lore along there.
We have another question, and I just want everybody to know that we did send a document of resources in the chat, which we can email out at the end of this presentation. We'll send it to everybody who's on the attendance list with their email. If you're not signed in with your email, you can just shoot me an email and we'll get it to you. The question, can you talk a little about the grassroots efforts happening in states with restricted or no abortion access to help women access AB services?
We could talk about the abortion funds. There's just about every state has a grassroots abortion fund, which is a network of people who provide financial and logistical support for people who need access to abortion. And you could go to, it's www.nnaf.org, nnaf.org, and they have a map, and you can connect depending on what state to the local abortion fund. They need money, they need volunteers, they need help, because they're getting overwhelmed with people reaching out to them for support. But I would say, like, from the patient end, I think that's one big thing that's really happening right now in terms of supporting people getting access to abortion. I don't know if y'all want to add on to that.
There was a great Atlantic piece that just came out, I think last week, their cover story, and it talks about all the things that are being done across the country, including people teaching how to, lay people how to do a MVA with a mason jar. So there's a lot of things happening.
And a breast pump.
Yes.
Yeah.
Another question from one of our Institute providers who's noticed a subjective downtrend in abortions in our clinic. She's wondering if we have looked at this and if there was a thought that it was due to higher access to teleabortion services.
Yeah, I wanted to mention that aid access only charges $150 for an abortion. So when people are uninsured and, at our health center, we have a pretty low cost for abortions, but we can't put abortion on a sliding fee scale like we do everything else. So we still charge $375 for an abortion at our FQHC network. So if someone is uninsured, they are definitely going to turn to the online resources where they can get an abortion for $150. And I think that that's been that's a growing resource that people are using. It's also so much more convenient than coming into the office, than having to call and make an appointment through our call center. I can imagine that it would be pretty inviting, to get your abortion through aid access, rather than, especially because there's Maggie, who's a local provider, and you can get your pills within a few days.
And Dr. Prine, is that the price for MVA and MAB?
Well, you can't get a telehealth MVA. So, but at the Institute, yes, that's our price for either procedure or pills is $375, because we don't want cost to be a decision maker for people. We want them to do what they want to do. And so, yeah, we keep the cost the same.
So we have some providers who have private practices on this call, and they're wondering, how would a private practice doctor like themselves get training?
Well, there are offerings that the fellows do along with RAP about every 2 or 3 months, trainings, which is the same as basically the training they're going to do with the Primary Care Development Corporation. So if you want to write to Lisa, she put her email address in the chat. We can connect you to the next training we have, or you could attend the PCDC training.
I'll put a link to the PCDC training sign-up sheet in the chat. Let me just get it.
what are the advocacy arms of medical societies like AMA and AAFP, etc., doing in preparation for what may be coming and marshaling the medical providers to impact forthcoming changes?
Well, we founded a member interest group in the AAFP for reproductive health care, and that group has been actively changing the orientation of the AAFP to be pro-choice. So they are now weighing in on each change, as mentioned earlier in the talk, that comes along. The AMA, we have done some infiltration, but not as much as we did in the AAFP. And we are also trying to work in NP organizations, PA organizations, midwifery organizations, moving all of our professional societies into activism to defend our scope of practice, to make sure that it's supported, that abortion can be done by advanced practice clinicians and primary care clinicians. It is one of the restrictive legislative things that gets passed from state to state, is that only OBGYNs can perform abortions, and even pill abortions, which is ridiculous. So yeah, there's lots of advocacy needed around these issues.
I have another question here. Do all OB-GYN training programs teach residents about medical and surgical abortion? Is this knowledge a requirement for board certification in OB-GYN? Little.
So
it is part of their ACGME.
yeah, but I was just doing research because I saw the question and I wanted to be able to provide you with an answer. Only 51% of OBGYN programs are providing integrated abortion training. So that's half. So they're required to do it. So that's a scoop.
The scoop. Another question here. Could you talk a little bit more about the Institute's reproductive health programs generally?
Lucia, you want to take that one?
Yeah, so at definitely the 2 downstate residency programs, we offer full spectrum reproductive health training to all of our residents. We do use an opt-in model, but they all get training in LARC, endometrial biopsy, colposcopy, as well as ultrasound training, medication abortion training, and manual vacuum aspiration training. Due to COVID, some of our manual vacuum aspiration training has been limited. As COVID improves and restrictions around training improve, as far as them being able to access training, we're hoping to be able to train as many residents as we're able to. The last couple of years during COVID, we have been lucky enough to train 1 to 2 residents per year in manual vacuum aspiration. And any of our residents who really want to be able to do ultrasound training and medication abortion training that is an option for them. We would love to be able to expand and have over many years talked about being able to expand more services up into Mid-Hudson and the Kingston region. We haven't been able to expand as much as we would like to. Along with that training also comes the other piece of reproductive health, right? Is training around prenatal care, miscarriage care, ectopic care. Really, our goal is to train residents to take care of the whole person, the person that presents in our office, the person that has high blood pressure and diabetes, and also needs care with their abortion care or their prenatal care or their ectopic care.
Thank you, Dr. McClendon. All right, another one here. Could you talk a little bit about other themes you were learning on the M&A hotline?
I think the most important thing that we have learned on the M&A hotline is that medication abortion is really safe. We almost never have to send anybody to the hospital. Our main role has been to reassure people that what they're going through is normal, because it is. When they call us and they say, I just passed a clot the size of a lemon, we're like, yeah, that's what happens. And we're reassuring people and telling them, that what they're experiencing is what they're supposed to be experiencing. And that's been reassuring to us, because we were worried about all these people out there with no access to anyone to talk to and what they might be going through. So the other thing that we do coach people on is sometimes people are just really panicking and they think they need to go to the hospital. And despite our reassurances that they don't need to, we know that in the back of their mind, they're still wondering if that's what they should do. So we coach people on what to say if they go to the hospital so that they aren't found out for having self-induced an abortion, which is illegal in some states. So our coaching is to tell people that they just say that they're having a miscarriage and that there's no way medically that any clinician can figure out whether or not they used abortion pills. There's no blood test for abortion pills. There's no exam that would reveal that they used abortion pills. So that is a really reassuring piece of information to people to have. But mostly we're telling them that they don't need to go to the emergency room. The other piece of information that we've gleaned from the hotline is that when people are anxious, it's really hard to navigate a website to figure out how to get your pills. And we end up coaching people through how to navigate the Plan C website over and over and over again, to the point where we're trying to figure out if we should change the hotline to having if you're calling about medical problems, press 1. And if you're calling about logistics, press 2, and get another whole volunteer staff of non-medical people to answer the press 2 and talk people through where to access their pills. But, you know, that's another exploration in the realm of what's legal and what's not legal. And, you know, whether or not somebody could get themselves in trouble for giving that kind of advice. We kind of feel like as clinicians, we are protected because the vast majority of what we're doing is medical. And it's just a little scary to ask non-clinicians to do this work. So we're trying to figure out where to go from here. It's a dilemma we have not solved yet.
So I kind of wanted to expand upon that a little bit more. It came up in the grand rounds that was recently done by our fellow at the University of Michigan, like what is required by physicians who are counseling or patients, or may have a patient that comes to them with questions about self-managed abortion, especially if they're like in a red state. So actually there are no laws currently mandating that physicians report that a patient has self-managed an abortion. And in doing so, that actually potentially is a HIPAA violation. So if you encounter a patient like that, you do not need to report. You do not need to feel like you are breaking the law by caring for the patient and not reporting them. There are no laws, and it could potentially be a HIPAA violation.
I'd also add that I think, kind of as you both sort of mentioned, it really is like a safety line, because when people are in these hostile states and they're self-managing their abortion, they're scared and they have nobody else to talk to. And so they really, just a friendly voice who's not going to tell them they're doing something wrong or they're in trouble, or is the most important reassurance.
I think we made it through all of the questions in the chat. The only questions that we haven't, I think, discussed were answered in the Q&A box. I wonder, are there any more questions? Oh, here's another one. Where do people go if they're considering an abortion for True Options counseling?
I think we give True Options counseling. We're not invested in people's decision making. We want them to do what they want to do. I know over the years people have said to me, "Do you want this patient to see a social worker because they're not sure what they want to do?" And I feel like this is our training. Our training is to be patient-centered, to let them decide. In some ways, I feel like our options counseling training is the backbone of the patient-centeredness that we try to teach in family medicine, because we are truly not invested at all in whether or not somebody has a baby or doesn't have a baby. We want them to do what they want to do. I mean, I know we do have to check our own biases and be really careful, because I have certainly been challenged, when a 44-year-old patient who is pregnant for the first time ever and comes to me for an abortion, and I'm thinking in my own head, oh my God, this might be your last chance to have a baby. Like, you may never get pregnant again. You may never get that option. I cannot go there in my discussion with that patient in that, I got to keep my mouth shut about that stuff. So, but that's how we train our residents to, it is what she needs and her decision alone. And we're just there to listen and to help her flush it out. Sometimes we suggest people come back another day, make a list, do a pros and cons list. There's even a pregnancy options workbook that has been created for people to walk themselves through. It's true options counseling is what family physicians should be able to do, and all family medicine clinicians, nurse practitioners, and so forth.
Thank you. States are using hospital privileges to restrict providers. Can you speak to that?
Yeah,
I would just say that that's, oh, go ahead.
I was one of the expert witnesses in Arkansas when they were trying to do that. And this has been a common court case all over the country. It was one of the issues in SB 40 in Texas that was actually won in front of the Supreme Court, because it was declared an undue burden to make physicians have to have hospital privileges. So I don't think that is on the menu right now because of SB 40, which did go in front of the Supreme Court and was won by Whole Women's Health. But yeah, it's in the menu of things to restrict abortion.
I think that this question has already been addressed, but again, is there a mechanism for faculty to train or retrain on abortion care? There used to be an option to go to Planned Parenthood on Saturdays for an intensive training, for example, or perhaps an option for faculty to participate in a procedure clinic just to update their skills. They've been out of practice.
There are clinics that do abortion training, and I'll put the link in the chat. But you have to commit to providing the care. You have to say that after you get trained, you're going to do it. So I will put the link and definitely go for it. That's especially for procedure training. They're very interested in training people in terms of doing aspiration abortion.
I think the question was maybe also at the Institute. People were asking if they could come back and get retrained. And there are certainly openings in some of our procedure clinic sessions where we don't have trainees. Often at Cadman, I'm there substituting for Jana and have no learners. There are times where Walton site doesn't have any learners. We would welcome anybody who wants to come back and work with us and get their skills up. That would be great. So just, get in touch and talk to the schedulers.
And just make sure that we have some form of credentialing done for them. So visitors can't just come in and start doing procedures. Even if you trained with us, you need to be there in some official capacity as a student, a resident, a fellow, a faculty person. You can't just come in as a visitor. And as much as Linda would love to do that, I think we have to, just follow the guidelines and all will be fine. I think we're pretty much out. This has been an amazing opportunity for people to hear, I think, not just about abortion, but about what role advocacy can play, for our patients. And we are advocates in many areas to make sure people have access to all of the care that they need. And Linda's done, and Lisa, for many, many years, have been promoting this and building this. I can't believe that you have thousands of materials and stuff like, it's just, even people that are working with you don't know all of the things that you're doing, which is amazing. So Red, I see you're on.
Thank you. This is transformative and inspiring. All I can say is in the area of education of family medicine, the work that you're doing and the role that you play nationally has really brought a lot of people, particularly dedicated advocates, to see family medicine is the way to take care of women and provide care to women. And, you know, just applicants that come to our program and students from affiliated schools see family medicine as the place to make a difference because of your work. So it's not just around this, it's really, I think you've transformed family medicine, and we're eternally grateful and just look forward to continue your support and prepare for what's going to be a challenging next few years. So thank you very much.
Thanks, everybody.
All the panelists. Yep.
Wonderful.
Take care.
It's good to see everybody again. This is a great community. Thank you.